All right. So this is about the venous pressure, okay? That's quite anticipated, that's quite normal, there is no problem in it. Edema develops in many females, lower limb becomes swollen. Not in every female I'm saying that, but there is slight increase and congestion is there. It is quite natural. It is over after pregnancy, okay? As the pressure is gone, delivery of the baby occurs, it's gone. Look at the kidney changes, urinary system changes. All right. Now, a very interesting point about the urination. In the early part of the pregnancy, sometimes females, okay, when they don't know about their pregnancy, they are not aware of it, okay? The cycle may have been stopped, but cycles can stop otherwise also. There is a delay of cycle, amenorrhea can happen due to stress also. Sometimes there is a tawil cycle also, they are not sure about it. In the early part of the pregnancy, when the female is unaware of it, sometimes there is a change in the urinary habit. Again and again she has to go to the bathroom and passing urine, okay, a little. It's called the frequency of micturition. It happens in the early part because the uterus has now started developing. She doesn't know about it. No pain, no symptom, no other thing. Only uterus is slightly expanding and it is exerting a pressure over the, all right, bladder. All right, and that stimulates the bladder and there is frequency of micturition. So in the early part, in the first trimester, the reason of frequency is increasing size of the uterus, because uterus is present in the pelvis. It is not up, it is not increasing, only expanding, and it is going and compressing it, okay? Uterus can easily compress the bladder. It can also compress the rectum, but rectum is not easily compressed in the initial part. The bladder is affected more. So the first change which is coming is frequency of micturition. In the middle part of the pregnancy, middle trimester, when the uterus is growing here up, it is out of the pelvis, the pressure is released. There is no pressure on the bladder. So again the micturition becomes normal. The frequency comes back to normal. In the last part of the pregnancy, in the last month of the pregnancy, especially the last 2 weeks or so, okay, 1 week or 2 weeks, again she starts having a change in the frequency. Why is it so? Yeah, the baby is now, the head of the baby is now engaged. It is coming down in the pelvis and it is fixed just above the birth canal, okay, because now the baby has descended and anytime the birth process can start. So when the baby descends and the head is engaged, then that head causes again a pressure on the bladder and the frequency restarts. So if a woman is in the last part of the pregnancy and all of a sudden she feels that her micturition is changed, now this means there is most likely engagement of the head and the labor can start in few days really, okay? So frequency of micturition again changes. In the early part of the pregnancy and in the very last part of the pregnancy, there are the mechanical reasons why we have it, okay? Look at the figures. I'm not reading it for you. What changes do you see really, okay? Just have a look. Have a look what is happening here. Changes, okay? Is there any anatomical change happening in the cube? Okay, yes, definitely. Now look at the physiological and the biochemical changes which are happening here, okay? So physiologically what is happening? Renal plasma flow is increased and the GFR, so is the GFR. If renal plasma flow is increased, definitely the GFR is increased. You can see that, right? What else is increasing? Okay. There are some adjustments of the hormones. Renin-angiotensin system gets activated and it will cause, yeah, okay. It will try to make adjustments. Will it affect the blood volume also? Yes. How? Aldosterone, okay. Through this system actually you are calling aldosterone, isn't it? And aldosterone will affect the blood volume. So this is a complete system for maintaining the blood pressure also as well as for calling on the aldosterone, right? Okay. One more change. Oh yes, okay. In the pregnancy, Again, there is a challenge, and the challenge is your glucose homeostasis. Even the normal females, their tolerance changes for the glucose, and there are chances of glucosuria. Okay, glucosuria can happen in pregnancies, not all females, but it can happen, and glucosuria up to 50% really. Okay, why glucosuria? First of all, increased load of glucose is coming, the GFR is increased, okay, first of all. Secondly, there is some hyperglycemia which is happening in the pregnancy, and the reason being insulin is not working very well. Okay, resistance. Why resistance? If you see, there are some enemies of insulin, hormones. Now, yeah, placental hormones, okay. So now they are making a group. You have high amount of cortisol already in the pregnancy. You have high amount of placental hormones like placental lactogen. The growth hormone from the placenta is increased. So 3, 4 or 5 hormones which are hyperglycemic hormones, they are موجود in the pregnancy, and on one side only wahid insulin is موجود. Okay, so insulin versus those hormones, insulin has to fight really, the resistance increases. Okay, all right. One thing is decreasing here in the slide. What is that? Okay, serum creatinine level, uric acid and urea nitrogen, okay, that decreases. The question is it due to production or yeah, something wrong with the filtration, or maybe due to the what could be the other reason? No, serum levels are decreasing. Okay, one thing is that it is more excreted, right? This is one thing. What could be the second thing? Dilution. Okay, Ryan is saying one. So you are considering two ends. One end it is excreted. Okay, more filtration and less reabsorption of some few of the things, and probably it is more. One factor. Both factors can operate. Ryan is saying that maybe because there is more plasma volume and dilution, that also changes the blood values of these things. It is possible, plus a slightly more excretion. These two factors multiply and they will give you a slightly low level. Thanks a lot, both of you. Great thinking. Okay, look at what is happening here. Furthermore, please. Yeah. Why? But renal pelvis is kind of a muscular structure. Okay, it's a tube-like structure, dilated structure. Ureters. Okay, before ureters, if you go up. So why would they be? Compensation. What could be the most likely reason for dilation of the this pelvis?
Due to the compression of the ureter.
Yes, compression. Okay, go for the mechanical reason first, because when the uterus is growing, it is compressing the ureter, isn't it? So ureters are being compressed and there is mechanical obstruction from outside. When they are obstructed, then the back pressure goes, and it's chronic. It's not 1 day or 2 days. Daily, it's a pressure. So there is slight dilation of the ureter. So which one will happen first? The dilation of the ureters or dilation of the pelvis? Ureters. And slowly and gradually it will go up and up and up, and that will cause slight dilation of the pelvis, and later it will affect the size of the kidney also. Okay, so there is a compensatory increase in the size of the kidney plus mechanical obstruction, which is not very much, but sometimes it goes in up to the level of the pathology also. Hydronephrosis can develop really. Okay, yeah, physiologically, but it can happen and it is over. It's reversible after the delivery of the baby. Everything is normal. So in extreme conditions, especially when there are twin pregnancies or a very heavy baby is mojood inside the mother and the size is very big, the baby's size is very big, then obviously mechanical effects are more. Okay. Bladder capacity is reduced because when the uterus is expanding, the bladder becomes like less place available for bladder, like this, okay?
Why the right ureter especially?
Right ureter is dilated usually because of the anatomical structures. The growing uterus has a chance slightly and it rotates slightly to the right side, and the underlying ureters, the retroperitoneal going back side, they have a more chance of compression, okay, because of the anatomy of the growing uterus, okay, and the anatomy of the intestines which are present on this side, okay. So right ureter is slightly more vulnerable as compared to the left one because of the normal anatomy of the person and the growing anatomy of the uterus also, both things, okay. Look at the pulmonary changes, the respiratory system, please. Have a look at the respiratory system. What is happening in the respiratory system? Look at the changes. Respiration. Okay, definitely it will increase. Everything has to increase because you have to supply oxygen to the fetus, growing fetus. So you can very well think that it will grow, definitely. Increased vascularity of the mucosa, overall tract, okay, right from the nose up to the level of the alveoli, there is a change, the vascularity changes and there is more congestion, okay. Even the voice becomes a little heavier because of the congestion of the mucosa. She has a problem and she can feel that there is stuffiness of the nose also. Sometimes nose bleeds start very easily because more blood is present in the nose, in the mucosa, all right. This is happening. Apart from that, changes in the subcostal angle, because when it is growing, the angle, the xavia, it is compressed actually, okay. The circumference and the diameter of the chest will also change as the pregnancy is approaching higher and higher, okay. That will compress the size of the thorax also because diaphragm will be compressed against like this, okay. Diaphragmatic excursion, what do you mean by that? Diaphragmatic excursion. You have done the examination of the respiratory system, yes or no? If you have done it, then you should tell me the meaning of the word excursion. What is the meaning of the word excursion? I am doing examination on Abdul Rahim, okay? Chest examination, remember palpation. I put my hand like this here and ask Abdul Rahim, take a deep breath. Expansion. So the movement of how much is the diaphragm moving up and how much is the chest expanding. This is excursion of the chest, okay. So diaphragmatic excursion, the range of movement of the diaphragm, should it increase or decrease? Definitely. If the baby is growing like this, can the diaphragm goes even with a deep breath? Mother cannot because obstruction. There is an abdominal tumor, isn't it? You don't agree with me? Tumor means swelling. The physiological tumor, which is the most common tumor in the woman, is pregnancy. Okay? So pregnancy is the most common tumor in the life of a female. You always think of tumor as a horrible thing, but tumor simply means a swelling or increase in size. So pregnancy is also regarded sometimes as a physiological tumor, okay? It grows and then it is gone, okay? All right. Oxygen, partial pressure increases, carbon dioxide partial pressure because the rate of ventilation increases, tidal volume is increased, okay? And overall per minute ventilation is increased. If the minute ventilation is increased, what will happen to the acid-base balance? Slightly change. What kind of change? If there is more ventilation, slightly towards alkalosis. Which type? Metabolic or respiratory? A very slight change in the pH of the blood, and I'm not saying much, but it has a potential of becoming respiratory alkalosis in the mother if it increases more. All right, mild, very mild. Okay. GID changes. Have a look at the GID changes. All right. Okay. Right from the beginning, there is nausea and vomiting. Okay. Morning sickness is there. It's very famous. Everybody knows that. Okay. The females have a problem. Okay. They become like nauseating all the time. Sometimes it aggravates and increases very much. And for the first few months, they keep on vomiting. Okay. Even they smell something. Okay. And they don't like it. Especially because the females are concerned with matbakh and cooking all the time, definitely. Well, a woman is a mother also, and she has to carry the responsibilities. Whenever she goes into the matbakh and the food is being cooked, that semi-cooked food and the steam which is coming on, the smell of that always causes a nausea, and she cannot stay there really. So smelling anything which is not favorable can bring, and she can throw it up very easily. Okay, so nausea and vomiting all the time. Okay, doesn't like the food. Okay, so this is one of the problems. Some discomfort in the abdomen. Later on, okay, she also has some fullness. She doesn't feel like eating much because there is slowing of the gastric emptying. Why? What could be the reason why gastric emptying is slow? One is mechanical. For example, it's not that much really. It's the middle part of the pregnancy, and the mechanical compression is not very much. Okay, in the middle. So what else could? Yes, this is one of the reasons. I agree. Okay, what else? Hormones. Very nice. Which hormone? Think. You are called slowing of the gastric emptying, slowing down the stomach. So it means you are relaxing the stomach or stimulating the stomach? Relaxing. Which hormone can relax? Pregnancy hormones, the major pregnancy hormones, the most important hormones of pregnancy. Okay, so you agree with the word progesterone? Progesterone generally decreases the tone of the muscles. Very nice answer. Thank you. Okay, it's progesterone. Progesterone is increasing, and that is relaxing the muscles, so motility of the GIT is decreased. The sphincters, the upper gastric sphincter or the cardiac sphincter also relaxes, and the food does not pass forward easily. So there are chances of regurgitation and reflux acidity also. Okay, so that problem is also a heartburn problem, or a reflux esophagitis type of thing can develop in the pregnancy. Okay, heartburn is very, very common. You can see it here. The gums, they also hypertrophy and become bigger in size, and the vascularity of the gums is increasing. So what are the chances if you touch the gums, what will happen? Bleeding is common very, because heavy gums, big gums, and easy to bleed. All right, these are the changes. Okay, later when there is a big uterus present here in the abdomen, one of the effects also develop in the GIT. What could that be? Constipation also. Mechanical obstruction plus hormonal influence, both. Okay, constipation, slowing down of the GIT movements, and she doesn't feel bowel movements properly. Okay, look at the skin changes. Just observe, please. Have a look at the skin changes. What is happening? Okay, first of all, look at the face. What is happening on the face? Face. Yeah. Yes, tanning of the face, and you have the pigmentation, irregular pigmentation, typically happening in many women in pregnancy. Not all, but many women develop this kind of pigmentation, and that is, what is that? It has a name. You call it melasma. Okay, yeah, or cloasma. Melasma or cloasma is the name which is given. Here it's cloasma written here. The other word is melasma also for this one. Okay, so this kind of pigmentation happens. Okay, look at the abdomen. The abdomen is growing in size. First of all, what will happen to the skin? Stretching of the skin. the inner layers of the skin are ruptured, damaged. First they appear as white striae, white, and then there is pigmentation of those stria. What is causing pigmentation, my dear? Who is causing pigmentation? Melanin. And who is stimulating melanin? MSH, okay? The hormone, melanocyte stimulating hormone. That increases in pregnancy and that has an effect. So melanin pigmentation later increases. The stria gravidarum, we call these stria as stria gravidarum, all right? Gravidarum means in a pregnant woman, the stria are appearing in. You can have skin nevi, the red dots on the skin because of the dilatation of the blood vessels. The red dots can appear on skin, okay? Very small dilatations. And you can have the spider formations just like that. It is not very clear here, but you will see like a spider, ankabut, right? All right? And typical spiders are formed. The blood vessels are diverging from that, and you can see a center. So it seems like a spider. Spider formation, spider nevi, you can say that, okay? This is a word that we use. Vascular spiders are the spider nevi. There's a lot of itching also, and that itching is promoting, okay, the stria formation. One more thing you can see. Can you see a line? This one. This line is what? Linea alba. Normally it should be linea alba, it is there like, okay, but in case of pregnancy this alba changes to nigra. What does it mean? Dark line or the black line, linea nigra here. Again the pigmentation by MSH, okay. So this linea nigra is a feature of the pregnancy. You can see this is happening, and later it disappears after pregnancy. Usually it's over, becomes very light or it's gone, reversible. Okay, musculoskeletal system. Look at that. Do you see any change in the shape of the spine? Because when the woman is carrying the baby, obviously there is stretching of, because of the weight anteriorly, the shape or the curve of the spine has to change, okay? It becomes more curved. And this normal curve, that all of us have a normal curve, isn't it? Okay, it's normal. It's called lordosis, normal. That lordosis is exaggerated. That is increased very much really, and it becomes like this. Lumbar lordosis becomes too much prominent, and that's natural. It has to happen just in order to carry on, okay? And there are muscle aches also, stretching of the muscles in different parts of the body, abdominal muscles especially, or even in the lower limbs, okay? That will cause muscle aches or muscle pains are there, okay? So skeletal muscles, they have stretch, and there is lordosis. The ligaments and the joints, they undergo relaxation, especially the pelvic joints and the sacral joints, they become little relaxed. Why they become relaxed? In order to accommodate or increase the size of the pelvic cavity for the uterus really, okay? So hormones are there, very special hormones, and even estrogen, progesterone, and a hormone called relaxin. We'll talk about that hormone coming from placenta, okay? That hormone will cause relaxation of the pelvic joints, pubic symphysis and the other joints, just in order to make the pelvis more accommodative, okay? Look at the metabolism and look at the weight gain. The mother is gaining the weight. In pregnancy, about 12 to 13 kg of the total weight is increased from beginning to the end of the pregnancy, total. Look at the distribution of the weight. How much is the weight of the fetus? It's only like, yeah, 3.5 kilograms, bus, okay, out of 12. The rest of the weight is carried by, so the fetal membranes, the amniotic fluid, okay, the placenta, these structures. Now, go to the other side, maternal side. Maternal side, weight of the mother, the fat which is being deposited in the mother, the extracellular fluid volume which is increasing in the mother, they are contributing to the weight also. So weight is not coming from one place, it is coming from multiple areas. The fluid is increasing in the mother's body, mother's weight is increasing because of the fat deposition and growth of the tissue size. Okay. Well, from the fetus itself, from the fetal membranes and the placenta, the amniotic fluid is there, you can see. So many things are contributing to the weight, total weight of the pregnancy, which is about up to 12 kg, 11 to 12 or even more sometimes, it depends really. Okay. So proteins are deposited, fats are deposited, there is a positive nitrogen balance also, and I think we talked about the insulin resistance already, that there is insulin resistance which is causing hyperglycemia, and that could lead to glycosuria, or the urine may contain it. Okay, look at the few facts about pregnancy. Is an excellent adaptive phase, an excellent phase which is showing adaptation and gives support to the fetus who is growing inside the mother. And at the same time, mother is taking care of herself also. There is no complication in the mother also. MashaAllah, imagine, in true sense, we have seen in our own experiences, our homes, our communities, all over the world, women have the capability of bearing the children every year, isn't it? MashaAllah, some of the women, every year they give birth and they have 10, 12, 14, 16 like this. And it is not a joke. If we see our families, our especially ancestors, okay, we used to have big families. Now the families are reducing a little. Not in Saudi Arabia, but generally families are reducing. And here also in Saudi Arabia, the young generations, they don't afford to have like 10 kids or 12 kids right now. Like I'm saying 5 to 10 years back from now, okay? They will have 2, 3 kids and they are quite happy with that. They have to take care of that. But before that, if we see our fathers and forefathers, okay, MashaAllah, the families were expanded families and very happy. There is no problem in the family, okay? All kids were grown in a very good way, and mother, a single mother used to have 10 babies, 12 babies at a time, like every year, every 2 years, like that. So look at the adaptation of mother system, okay? That's why mother has a very high status. Just because of that bearing of the child, Allah has given the highest status to the mother. We all know that, okay? So this is the maternal adaptation, and that is causing changes. Physiologically, what is happening? Look at the volume inside. Look at the state of blood inside. Look at the state of metabolism inside. Everything is being controlled. So pregnancy is carried in a very successful way in most of the women. Some will have complications, okay. This is a deviation, but most of the pregnancies, there is no problem. There is no problem even in the delivery. Even if there is no one for delivery, the child can be delivered automatically and normally, really, okay? So it's a natural process. It is assisted, but it's a natural process. Anyway, the idea is that you have to close your discussion by thinking that pregnancy is a very special environment, a special phase, okay, which is giving a special care to the baby for the growth over a period of 9 months, and at the same time mother system is taking care of itself also. So both maternal homeostasis and fetal homeostasis, both are going side by side. If you remember one statement that we used in our respiratory system when we were doing the tutorial or a lecture, I don't know, I don't remember. It was about, I showed you a picture of Mount Everest, okay, in the lecture, okay, the opening slide, acclimatization lecture, if you remember, right, okay, and probably, I don't know if I mentioned or not, it's the time to mention it again here, okay. At the top of the Mount Everest, the partial pressure is only 30 or less than 30 millimeters of mercury, PO2, at that. And the same partial pressure is present in the uterus when the blood is flowing in the uterine vessels. So fetus is living under the same conditions, just like Mount Everest. As if I go or you go on the Mount Everest and we experience that, the fetus is growing there, but fetus is very happy and fetus is managing really. Okay, so there is a Mount Everest in the uterus. Okay, this is a very famous statement which was said 200 years, 300 years back actually. It's not a joke, because the same conditions are prevailing in the uterus also.